Hello, good morning, dear scholars and friends all. It's an honor for me to welcome you to the SELNET education meeting Cures News Ewing Sarcoma, organized by Instituto Nacional de Enfermedades Neoplásicas, Lima, Perú, INEN, with events today. I'm very happy to be together today, an opportunity to develop and share knowledge. Through the science, knowledge, experience, and ideas of the most outstanding scholars and researchers whose company as today. Today we are pleased to have Gaspar speaker who will develop the things, new drugs in Ewing Sarcoma, the role of high-dose chemotherapy, news in advanced Ewing Sarcoma. Ewing Sarcoma is an aggressive form of tissue cancer. Ewing Sarcoma arises predominantly in children and young adults. Current management of primary Ewing Sarcoma will rely on the combination of chemotherapy and local reduction by surgery and radiotherapy. Cases prove the 6 years survey rise among patients with local disease for 10% in the era before chemotherapy to about 70 currently. We have seen today use management strategies, dose intense drugs, high dose therapy with autologous stem cell rescue, and dose intense drugs short interval between those intervals comprises. We have to Euro why chemotherapy, why with Cristina y familia, Dr. Cristina and Dr. Cristina, why high doses chemotherapy. We have to high doses chemotherapy comparing with standard chemotherapy and long reduction in Ewing sarcoma with pulmonary metastasis. We have to interval compression, why every 2 weeks for 3 courses follows, local control follows every 2 weeks for course. We have 2 new treatments such as research in the small molecule treatment in the inhibitor of the FTC fusion protein, treatment the antibiotic Y enoxaxine, treatment of the internal distributors LCD. We have 2 treatments in advanced disease, Y gemcitabina and nab-paclitaxel, Y cabozantinib, Y taloxactinib in combination with tremoloxamine. We have 2 clinical trials with question why in the answer in the management of local disease and advanced disease. We start the clues. Please, Dr. Haro, will continue with the presentation of the expert speakers.
Good morning. Can you hear me? Okay. Good morning to all the attenders. I am Juan Carlos Haro. I'm an oncologist here in Lima, Peru, in the National Institute of Health of Neoplastic Disease, INEN. We thank all the members of the SELNET consortium for the opportunity and facilities to hold this important event, especially Dr. Brot and Dr. Nadia Hindi. To start today's activities of the SELNET consortium, we are pleased to have a participation of the experts speakers, Dr. Natalie Gaspar from France, Dr. Rachel Windsor from United Kingdom, and Dr. Emanuela Palmerini from Italy. Next, we will ask you to silence your microphones during the presentations, and after each presentation, we will have a small round of questions, and you can send your questions to the chat. As the first speakers, we are pleased to present Dr. Natalie Gaspar. She's a pediatric oncologist and an adolescent and young adults unit coordinator at the Gustave Roussy Hospital in France, who will tell us about new upcoming drugs in Ewing sarcoma.
Good afternoon. I'm very pleased to be here. I will do my talk in English. I hope next time I will be able to do it in Spanish. I'm, as you said, a pediatric oncologist, but I'm also the pediatric chair of the French bone sarcoma group, which is called Groupus. And I will try to talk to you about new upcoming drugs in Ewing sarcoma. Can you see my slides?
Yeah, we can.
Yes, it's okay, Natalie.
Then first, I wanted to set up a little bit the context of phase 2 in Ewing sarcoma, which in relapse Ewing sarcoma, which is the way we evaluate these new drugs. We have done a systematic review where you can see that in 13 years, there have been quite a lot of trials open for Ewing sarcoma from phase 1 to phase 2. Multiple drugs that have been tested, a third of targeted therapies, a quarter of chemo, 20% of immunotherapy, and a quarter of therapies that are combined. However, the way these phase 2 are run are very, very different, with different inclusion criteria. Age that is can usually start at 18, which is a nonsense in this disease, as 90% of the relapse are patients that are above 12 years, and very few of these phase 2 start at 12 years. These phase 2 are also run for measurable disease according to RECIST, which means that you have to have at least one lesion of more than 1 centimeter in an extraosseous localization. Or we know that some of these disease relapse are non-measurable, and a quarter of the patients with non-measurable disease have no access to this phase 2. And the other thing is that the primary endpoint are very variable from a study to another. And most of the study have used response rate. Very few have used PFS. And now we know that from the RECUR study, which is a study that is going on in Europe, comparing different chemotherapy regimen at first relapse, that response rate is not a good primary endpoint, because response rate is not correlated to either to PFS or to overall survival. Then if we want to have a more reliable way to evaluate the drugs that we are using, we should use PFS. And you see that with chemotherapy, the PFS is around, the median PFS is around 5 months. And if you look to all these trials that have been published up to 2018, the results were quite disappointing. The response rate was very poor, less than 10%. The median PFS was only 2 months. The median overall survival, only 7 months. And the more worrying thing is that 20% of the trial only were considered positive, but if you look to the criteria that make them positive, they were very variable. Response rate was around 4 months. Response rate was around 15%. The median PFS 4 months, and the median OS 16 months. Sorry, it's a little bit in French. But at the end, there were some studies with exactly the same results that were considered as negative, which means that it's not really easy to interpret what is the efficacy of a new drug in a phase 2 in relapse Ewing sarcoma. Then just to introduce, this was just introduced, you will see everything that I will say on the next new drugs that is not so easy to interpret. As you know, Ewing sarcoma is a very simple, in theory, oncogenetic tumor with an oncogene fusion that should render normally this very easy to target. But as you know, this has been a huge problem in the since we know Ewing sarcoma. The only drug that is trying to target not the fusion, but the interaction of the fusion with the DNA is the TK216, which is a drug that disrupt the RNA helicase A interaction with AWS3-1 transcript. And inhibits the abnormal transcriptional activity of the Ewing fusion. This drug has shown some efficacy in vitro and in vivo, and some synergy with vincristine. There is a phase 1/2 ongoing on the US with a very complicated schema, with the first part that was dose escalation of the drug, then a second part that has a schedule escalation between 7 days and 14 days infusion, and then an expansion cohort in association with vincristine. First results were shown last year, and there were some updates this year at ASCO. What we know is that DLT is mainly neutropenia. The recommended dose is 200 milligram per meter square per day over 14 days infusion associated with vincristine. The tolerance is mainly due to myelosuppression, which is the main side effect, which is usually transient, reversible, and responsive to GCSF. But having a new drug with a lot of myelosuppression as side effect can be a problem then if you want to introduce it in first line with the chemotherapy that we already use. The second thing is that the efficacy doesn't seem so interesting, even if they have to prolong a complete response over more than 1 year. If you look to the response rate, but if you, and also to the median PFS, the median PFS is only of 2 months, which means not so important as compared to chemotherapy alone. The other way to try to tackle Ewing sarcoma is to target downstream pathway of EWS1. And as you know, there have been a huge hope with anti-IGF-1 for a long time, but this hope has turned to despair. For the hope was due to the fact that the very huge response were seen. However, this was only for a few patients, and at some point the disease was coming back. And up to now, more than 15 years after, we still don't know how to identify the patients that can benefit of this drug. And we still don't know how to improve the efficacy of this drug. Multiple combinations can be tried with other targeted agents if you look to the pathway of IGF-1R. The IGF-1R inhibitor have been definitely killed last year or 2 years ago by the result of the phase 3, the American phase 3 that was using an anti-IGF-1R inhibitor in association with the VDCIE chemotherapy in a randomized way, and they failed to show any added efficacy of this anti-IGF-1R inhibitor. There are other growth factors due to the biology of EWS1 that might be interesting in Ewing sarcoma and are still under investigation. If you look downstream this growth factor, you also have CDK4 and CDK6 inhibitor, but really it's very difficult to know what to think about these drugs. There is a rationale to use them because around 20% of the Ewing sarcoma have a deletion of CDKN2A. They have also activation of CDK4 pathway. And there is a rationale also outside the deletion of CDKN2A in Ewing sarcoma. There are multiple trials that are ongoing in combination with chemotherapy, but we still have no results at the moment. And there is also a targeted combination of targeted therapy, for example, CDK4/6 inhibitor associated with mTOR inhibitor in everolimus, everolimus in the eSMART trial, which is an European trial based on molecular profiling of the tumor. But in that trial, initially the arm B was just the CDK4/CDK6 inhibitor, and it was closed because no efficacy was observed. And Anti-tumor immunity was quite disappointing with the use of anti-PD-1 and anti-PD-L1 with not really an efficacy seen, at least as single agent, and we don't know which will be interesting as combination. Ewing sarcoma is a disease that is expressing poorly PD-L1 and have a low infiltrate of CD8 lymphocytes. An interesting path to try to tackle Ewing sarcoma is DNA repair and the PARP inhibitor. As you can see on the right, they have, among all the cell lines that have been tested for PARP inhibitor, Ewing sarcoma in blue are those that show the most sensitivity to PARP inhibitor. And this sensitivity to PARP inhibitor helps to synergize also with chemotherapy, either with temozolomide or irinotecan in Ewing sarcoma cell lines and in models in vivo. However, in patients is not so easy. Clearly, it was said that there is no interest of a PARP inhibitor as single agent in Ewing sarcoma because, as you can see, there have been no response, no complete response, no partial response, just some stable disease. But if you look to the median PFS is comparable to what you can see with chemotherapy. Then a lot of trials are trying to understand which combination can be useful in with PARP inhibitor, and based on the in vitro and vivo data, combination with temozolomide or with irinotecan have been being tested. We still don't have all the results yet, but what we know is that these combinations are quite toxic from a hematologic point of view and a gastrointestinal point of view. Then so far, we still don't know how efficient it is, and if we will be able to use that kind of drug with a more myelosuppressive chemotherapy. There are other combinations with PARP inhibitors that are being tried with anti-PD-L1 or more recently with ATR inhibitor. And there is an arm in the ISMART protocol that is open and where Ewing sarcoma can be recruited. What can we learn from precision medicine program? Then I told you about ISMART, which is a protocol that is based on molecular abnormality that has been found in molecular profiling programs. We have several molecular profiling programs in Europe, in France and other European countries, including Spain, Italy, and others. There is the MAPIACT study. And you can see that 71 patients with Ewing sarcoma have been included in that molecular profiling program. But at the end, very few additional abnormality are seen. You find the fusion, of course, in all Ewing sarcoma, but very few of them have additional abnormalities. And when you find them, it's mainly CDK4, CDK6, WEE1 abnormality, and there is at least a lot of other ones that are not very useful for targeted therapies. The ISMART protocol has several arms, and then you can include patients according to the abnormality that they have seen. The first square that you can see on the left are the arms that are already closed, and you see that the accrual of Ewing sarcoma in these arms have been very few, except in the arm D, that was a PARP inhibitor associated with irinotecan. But we still don't have the results for the Ewing cohort in terms of efficacy. There are other arms that are now opening in Recure, in ISMART. The one that I already told you, CDK4, CDK6 inhibitor plus mTOR inhibitor, the ATR plus PARP inhibitor. And there is also one arm that can be interesting in Ewing sarcoma, which is a pan-FGFR inhibitor. from the last year, what seems to be the more interesting drug coming in Ewing sarcoma are multi-tyrosine kinase inhibitor with anti-angiogenic activity. Several trials have been run, most of them were single-arm phase 2 at relapse. One of them was a randomized phase 2 against placebo, and that was the Regobone study. And in this Regobone study, you can see that there is an effect of regorafenib greater than the placebo one, even if this does not reach the target that I wanted to have. The difference is clear. And the regorafenib arm has a 3 months median PFS, which is close from what you can see with chemotherapy. And this is more or less the same with the cabozantinib. That was tested in a single arm in the Cabon. Then this drug seems to have an efficacy close from chemotherapy, but there is no randomized trial to prove that one is better than chemotherapy is better than multi-tyrosine kinase inhibitor or vice versa. There are now what you should know about side effects of this drug is that usually it's well tolerated. The side effects are linked to the anti-angiogenic activity with some fatigue, anorexia, but hypertension is not so often severe at least in children. And you have also hypothyroidism that is seen with most of the patients, but that is manageable with just hormonal substitution. And proteinuria is not so often. But anyway, due to this side effect, dose reduction is often seen in 20 to 40% of the patient, depending on the drug. There is also a risk of bleeding, of wound, a problem in wound healing, and the risk of pneumothorax for patients that have lung metastases, but it seems to be more seen with osteosarcoma than with Ewing sarcomas. What is the feasibility of using these drugs with chemotherapy? There are several trials that are ongoing in different diseases. Lenvatinib with ifosfamide and VP16 in osteosarcoma, which non-unexpected toxicity observed. Randomized trial is ongoing. There is regorafenib that has been tested with vincristine irinotecan with no additional toxicity and it's now tested in a randomized trial in rhabdomyosarcoma first line. There is also a combination with pazopanib in Temery. This was too toxic and stopped. But there are other combinations with pazopanib, especially with doxorubicin and ifosfamide that was well tolerated if the pazopanib was used as 70% of the usual recommended phase 2 dose. Then what we are trying now, we are trying to see if this can be useful at relapse. And there is in Europe a RECUR study that I already mentioned before that was testing different chemotherapy regimens. And now we are thinking about introducing the lenvatinib associated with ifosfamide and compare this arm in a randomized way with the ifosfamide alone, which will help to have idea of the toxicity, but also of the efficacy of adding multi-tyrosine kinase inhibitor to chemotherapy in the relapse setting. But what about the patient of diagnosis? If you look to the overall survival of patient of diagnosis, patient with other metastases than lung only, or patient that have a prognostic that is as worse as patient have relapse, then maybe we can try to introduce early new drugs in that kind of patients. There is now a study that should open in 2022, that will be done also in Europe and other countries over the world, where the idea is to introduce multityrosine kinase inhibitor with the VDCI-IE chemotherapy from diagnosis to try to improve the overall the PFS of this patient. And this trial has just get funded and should open in 2022 with the regorafenib associated in a randomized way to VDCI. If this phase 1 is tolerated and if there is some efficacy shown, then this therapy will be introduced in the first-line phase 3, not just for patients with multi-metastatic disease, but also for patients with lung disease. And that will be the first question of the new Ewing trial that will be set up in the next year in Europe. There are other questions in that trial, but they are not linked to new drugs that I will not talk about it. There is one question about radiotherapy and two questions about radiotherapy and one about maintenance metronomic chemotherapy. Combination of multityrosine kinase inhibitor with other drugs are also being tested, especially with immune therapy, but no data yet available. Targeted therapies, there are many others that can be tried in Ewing sarcoma and are still trying, but at the moment there is no huge efficacy that is that has been very helpful for the patient or that are efficient enough and tolerable enough to be introduced in first line. Then upcoming drug in Ewing sarcoma, it's more questions than really answer. At relapse, we should really think about how to improve phase 2 design. There is very few single agents that have shown efficacy and one class that have shown that is multityrosine kinase inhibitor. Which optimal combination to use these new drugs we still don't know, and how to introduce pure promising drugs or combination in frontline treatment is something that is not so easy. Thank you for your attention.
Thank you, Dr. Gaspar, for your excellent presentation. Now we have a few minutes for questions from the audience. Any question?
Yeah, good afternoon, Natalie. This is Javier Martin Broto. Thank you very much for your interesting presentation. I have a question about the main point that should be pursued in the phase 2 trials in Ewing sarcoma. It should be overall response rate, it should be progression-free survival, or what is your idea about that? What is your thought about the main point in these new drugs in advanced disease in second lines?
Yeah, I think it's a very complicated question. Clearly, what we have seen is that response rate is not linked to PFS or to overall survival. Then using response rate to decide which drug should continue or not to be tested in Ewing sarcoma, I don't think it's the best way of doing it. PFS should be probably the primary endpoint that we have to choose, but maybe we have to discuss with the statistician to try to see if double and primary endpoints are the way of doing things to be able to integrate PFS and response rates in evaluation of this drug. But I'm not a statistician, and I don't know what is the best way of doing it. But if we have just one choice, I will choose PFS. If we can choose more and be innovative, I will try to combine PFS and response rate.
Thank you.
I have a question
Any more?
regarding the PARP inhibitors in the clinical trials developed. Which was the biomarker or the molecular screening for those drugs? because BRCA mutations is not so common in Ewing sarcoma, so I guess it was more a BRCA-ness phenotype.
Due to the results of the what have been seen in vitro, just having the AWS-FLI1 transcript was a biomarker to be included in PARP inhibitor trials. Then it's supposed to be a biomarker-driven trials, but in the Ewing sarcoma, we can doubt, and it's maybe more a disease-driven trial.
Okay, thanks.
No more questions. Thanks a lot.
I don't know if someone is speaking, but I cannot hear anything.
Yeah. Juan Carlos, are you online? Juan?
Hi.
Your sound is not very good now, and maybe this is the reason we are not able to hear you. But if I can help you in the meanwhile if you are recovering this sound. But any other question for Dr. Natalie Gaspar, please?
I have a question. I want to know your opinion, because it seems clear that in Ewing sarcoma monotherapy is not so interesting. And sometimes when we try to target just one pathway, we found that the disease overcomes this blocking. So combinations seem to be key. And I don't know if translational research is being, because sometimes, for example, we found in vitro that EGFR blockage works, but then it doesn't translate in the clinical trial. So how can we improve the hypothesis or the translational research background to have more successful trials? Because it's sometimes it's very frustrating seeing that these preclinical findings do not translate in really clinical benefits. I don't know how we can improve in that way.
Clearly, we need the biologists for that. But even with a sometimes strong rationale in vitro or in vivo, the translation to patient is not obvious. The more different kind of models we have, probably the best to be able to have a greater overview of what can happen to the patient. But at the end, I think that only the clinical trial will give us the real answer. But what we really need to know, to try to do, is when you are doing basic science, when you are doing preclinical trial, is to always keep in mind that if you have a biomarker, it will help the clinician to better design the trials than thinking biomarker from the beginning of the development of some drugs.
Natalie, thank you for your conference. It was a very nice talk. I want to ask you if you consider when you design a clinical trial for Ewing, if you must make a different stratification in terms of age. You consider that Ewing in adults is different regarding the adolescents or the kids Ewing. Do you think that in new drugs is a consideration which age have the patient?
I don't know in terms of efficacy if it is if the age is important or not, but with some of these new drugs, at least age is important in terms of tolerance. With children tolerating at least at the acute phase better these new drugs than adults, which we have seen, for example, with multi-tyrosine kinase inhibitor. The first time we wanted to use it in combination, the adult medical oncologist told me that pediatricians were crazy because we will never be able to do it. But our experience as pediatrician was quite different in terms of tolerance, and this revealed true. Then clearly, at the moment, there is no difference between age, but this should be taken into account in the analysis probably to be able, after that, to better understand how we can introduce these new drugs more broadly.
Okay. Can you hear me now? Sorry for the problem. Thank you, Dr. Gaspar, for your excellent presentation. If there are no more questions, we are to continue with the next session. Next, we are pleased to introduce Dr. Rachel Windsor. She's a pediatric oncologist at the Pediatric and Adolescent Division of the University College in London Hospital of the National Health Service in London, United Kingdom, who will tell us about the role of high-dose chemotherapy in Ewing sarcoma.
Thank you very much, and thank you for inviting me to share this, and thank you to Natalie. That was really excellent. I'm going to just share my screen. I hope this works. Okay, can you see that?
Yes.
Okay, right. So thank you very much. So I'm going to talk about the role of high-dose chemotherapy in Ewing sarcoma, and thank you. That's a really great background that Natalie's given us. So I'm going to talk a little bit about the background specifically of high-dose chemotherapy and the principles, and then take you through some of actually the large randomized trials that have been performed in Europe, specifically in primary disease and aspects of primary disease, and then just present to you some unpublished data that we have reviewed at the London Sarcoma Service, which is just about to be hopefully published. But I just want to share that with you about recurrent disease and high-dose therapy. And then actually I've got long-term consequences on here, which is more perhaps a discussion, because I stopped my slides then because I felt that was probably too many. So just some background. Of course, we all know that that the overall survival of localized disease in Ewing sarcoma is between 65 and 75% at best, with multimodal treatment, chemotherapy, radiotherapy, and surgery. But of course, around just perhaps a quarter present with metastatic disease, and the majority of those are in the lungs, but also around 40% have bone metastases. And if you translate the sort of presentation into survival, then it's clear that the prognostic factors have been reported many times in many publications and studies, which the high-risk patients are those who have metastatic disease at diagnosis, large tumor volume, primaries in the axial skeleton, and a histological response with more than 10% viable cells at surgery. So that has sort of moving on from that, we know that of course as patients with primary metastatic disease and recurrent disease have a really dismal outcome, and although the reports in the literature vary, the patients with lung-only metastatic disease have the best 5-year survival. I think optimistically up to 59% is written here, but perhaps more realistically around 25 to 30%. And patients who have bone marrow, bone involvement, or combined a pulmonary and extrapulmonary disease have a very poor prognosis. And then in the patients with non-metastatic disease, at diagnosis, of course, 30 or 40% of those will relapse, and then they fall into this recurrent group where 5-year survival is extremely poor. So that has really led to the rationale for high dose chemotherapy, which is to try and dose intensify chemotherapy drugs to overcome the relative resistance of tumor cells to cytotoxic drugs. So this is based on a dose response rationale that increased drug exposure increases tumor cell kill, which seems very reasonable. And if you have a 3 to 10-fold increase in dose, it leads to a multiple log increase in tumor cell death. And this is particularly for the alkylating agents, which is why busulfan, melphalan, treosulfan are particularly used in high-dose chemotherapy. But of course, allied to this is the dose-limiting toxicity, which is primarily hematological with myelosuppression, and of course, stem cell rescue is a critical component of this sort of treatment. But there's extra hematological dose-limiting toxicities, particularly gastrointestinal, hepatic, veno-occlusive disease, are significant toxicities with this sort of treatment. So the principles of high dose really are that the tumor has to be chemosensitive at the time of high dose. It has to remain chemosensitive. And as we all know, patients who have multiply relapsed disease, their tumors become progressively less chemosensitive. A patient, of course, has to have adequate organ function to tolerate the treatment, and adequate stem cells harvested, which for some patients who are heavily treated is an issue. And then the choice of agent is probably the bulk of experience is with busulfan and melphalan, but there's reports of use of treosulfan, which has good in vitro activity against the Ewing sarcoma. There isn't any reported data that that busulfan is superior to treosulfan, but I think that may be because numbers are small. But so that's a sort of open question, I think. So, So just moving on. Before I start, just talk about high risk Ewing sarcoma. I just wanted to highlight this review by Natalie, actually, which has a really comprehensive review of all of the majority, or in fact all the publications that have reported on high dose therapy outcomes. So I don't have time to go through those now, but this is extremely comprehensive and very readable. So I just point you towards that review paper if you want to know more in depth about the specific studies. So high risk Ewing sarcoma. So I'm going to start with the results of the Euro-Ewing's study, Euro-Ewing 99 and Ewing 2008, which was a subsequent study just undertaken in France and Germany once Euro-Ewing's 99 had closed in the UK. And this had, as you know, had multiple arms investigating the treatment of primary high risk Ewing sarcoma, whether that was disseminated disease or high risk localized disease. So the localized disease arm was based on VIDE induction chemotherapy, which is vincristine, ifosfamide, doxorubicin, and etoposide. And of course, that was that standard of care at that time. And now we use the VDC-IE regimen based on the subsequent Euro-Ewing study, but that's a separate question to this. So high-risk patients in Euro-Ewing's 99 were denoted as those who had a more than 10% viable cells after surgery, large tumor volume at diagnosis, or just had primary radiotherapy, and those patients were randomized to VI as consolidation treatment, so vincristine, actinomycin, or ifosfamide, 7 cycles, or Bumel high-dose chemotherapy. And it was roughly equivalent, so 118 randomized to VAI and 122 to Bumel. The statistical plan was to recruit 328 patients, but actually the trial was stopped, as you can see, at 240 because accrual was very slow, and it became clear that the sort of randomization question was not palatable to either patients or their treating physicians, and that was based on the number of patients that did not agree to the randomization. So the median follow-up was quite long, nearly 8 years, and in this study, Bumel significantly reduced the risk of events. So you can see the hazard ratio was 0.64, which was significantly different to the patients who'd received consolidation chemotherapy with VAI. Toxicity, I'll show you in a slightly later slide, but there was more toxicity in the Bumel arm, perhaps predictably, more severe toxicity, but the authors did make the point that this was a one-off course of chemotherapy compared to multiple toxicities from 7 further cycles of VAI. And of course, what's very difficult about these findings is because there's a clear benefit to patients who have high-risk disease in terms of receiving high-dose therapy, but it's how this is translatable to now our standard treatment regimen is VDCIE, which is the interval compressed treatment, and actually can you apply these findings based on VIDE induction chemotherapy to a different regimen of chemotherapy. So that's difficult. So we're not, certainly in the UK, we're not offering high-dose chemotherapy for patients with poor risk treatment as we were previously after the Ewing 99 results. And this is just the survival curves, as you can see, that are showing the benefit to patients who had Bumel, and the characteristics of the 2 groups. And then this just shows the toxicity. Overall, Bumel was more toxic, particularly GI and liver, and severe sepsis. So as you might expect, but also as you might expect, VAI, so the high-dose ifosfamide, was caused more renal toxicity. So moving on to the next part of the another part of the Ewing study, this part of the study, so R2 pulmonary, looked at specifically patients with pleural or pulmonary metastases, and those were defined as one nodule more than 1 centimeter or more than one nodule more than 0.5 centimeters. And again, this was looking at post-VIDE induction chemotherapy with one further cycle of VAI to allow recovery from surgery, and patients were randomized to either Bumel as high dose or 7 further cycles of VI plus whole lung irradiation. And there was an amendment to this study shortly after it opened, excluding patients with axial tumours who'd had radiotherapy, excluding them from the Bumel arm due to a concern about radiation myelopathy. So as you can see here, there was no significant difference between the Bumel or the VAI arms with whole lung irradiation in terms of survival. And there were 4 toxic deaths in the Bumel arm and significantly increased toxicity in the Bumel arm. So this was reported as no benefit to Bumel in patients with pleural or pulmonary metastases only. So just moving on to think about how the management of primary disseminated Ewing sarcoma. So this was a further arm of the Ewing study. And the disseminated, the metastatic disease arm recruited 281 patients. Again, they had standard VIDE induction, and if they were deemed to have responsive disease, then they could proceed to high dose chemotherapy. And so 169 of those 281 patients proceeded to have high dose therapy, and the vast majority had Bumel. 8% had ME, and then there was a handful of other regimens. So the patients who didn't have high dose chemotherapy, of which there were over 100, these were really mainly patients who didn't have responding disease, or early progression or an unsustained response to chemotherapy. Choice made by the physician, or a failure of stem cell collection, which precluded having high dose. And so the toxicity was perhaps as expected. The treatment-related mortality in the Bumel arm, 6 patients died, 3 early on and 3 later on from high dose related toxicity. And the survival of all patients was around 27% at 3 years. The patients aged less than 14 had a superior survival of around 45%. So this and the outcome after high dose, 3-year event-free survival, there was a clear difference in patients who were in CR, PR, or stable or progressive disease when they went into high dose, with the patients in complete remission having a 57% survival. But there was no, because this wasn't a randomized study, there was no comparison made of patients who non-high dose versus high dose. So overall, I can just show you the survival curves, and the prognostic groups that they found were as we might expect, particularly the patients who had an increased number of bone metastases had an increased risk of poorer survival. But as I said, there was no high dose versus non-high dose comparison. So what was reported was that, again, was the prognostic importance of the tumor volume, bone marrow and lung involvement. So combined metastatic disease, and particularly the number of bone lesions that you can see here. So once patients had 2 or more bone lesions, their risk of death was increased. There's a lot of there's many publications, but few conclusions, and that's really based on the lack of randomized trials. And I think the European data from Ewing's 99 probably represents the largest randomized data that we have, specifically looking at high dose chemotherapy in Ewing sarcoma. And as Natalie mentioned, RECUR is the current phase 3 trial, which is open, investigating optimal treatment for recurrent or refractory Ewings, but there's no appetite to add a high dose arm into that. So the prospect of having a randomized trial looking at high dose therapy again, I think particularly in recurrent disease, is very unlikely. So in summary, really, I think the data doesn't support a role in primary disseminated disease or primary pulmonary metastatic disease, but and there is a role in poorly responding primary disease. But how do we translate that into the current chemotherapy regimen that we use? And I think there's data accruing on the use of high dose therapy in recurrent disease for selected patients, so particularly those with local or pulmonary recurrences, if they are chemo responsive. But it comes down to perhaps how fit the patient is and a frank discussion about the risk benefits and toxicities and what it might achieve for them ultimately. So thank you.
Thank you, Dr. Windsor, for your presentation and the important message you leave us. Now we have a round of questions from the audience. Now we have a question in the chat of Andres Rodriguez. In your experience, at what age cutoff point do you consider using HD chemotherapy for high-risk patients?
So, I mean, I'm a pediatrician, so my cutoff, I look after up to sort of young adults, so 24-year-olds. So we wouldn't have, if they had chemo-sensitive disease and sufficient organ function, then we would put them through high dose if we felt, you know, in like a recurrent situation. I think you know, obviously I work closely with adult colleagues, and there is much less appetite for high dose in adults because of the toxicity. And I think you know, I think the disease perhaps behaves differently. Apart from the resilience to treatment, the disease behaves differently in older patients. Certainly the data from Ewing's potentially showed that.
Okay, thank you. The second question is, has NICE incorporated HDT for Ewing?
No, it's actually certainly in upfront treatment, no, and the choice of using high dose for relapsed or refractory treatment is really dependent on, I think, the treating unit. Certainly in the UK, I don't know what the other units do, but we base it on an MDT decision in terms of extent of disease and the chemo responsiveness and the fitness of the patient. Although I wonder if we've sort of almost gone in a bit of a circle, that we'd stopped considering it at all, and we're going back to thinking about it much more, although we don't routinely harvest patients, you know, up front like we used to do. But it's certainly not approved by NICE.
Okay. I have one question. What is the best time to do the harvest, and what is the best scheme of chemotherapy for do that?
So in recurrent disease, or do you mean in recurrent disease recurrence? What's the best time and best chemo? So I think there's some evidence that high dose ifosfamide may give a superior outcome, but of course RECUR is looking at the responsiveness to different chemotherapy regimens at the moment, and high dose ifosfamide is one of the arms which has remained in the study as giving the best outcomes until now. In terms of harvesting, I think if you're considering high dose, you need to have evidence of a disease response. So at least 2 cycles with responding disease, and then perhaps if you're aiming for high dose, then consider harvesting after perhaps the third or fourth cycle.
Thank you.
Juan Carlos, I guess in high-risk localized disease is after bite cycle, I guess the harvest of the stem cell is according to your protocol, Dr. Windsor?
So when we invite chemotherapy, yeah, I think there was harvested after about cycle 5, but we've because we've switched to using VDCIE interval compressed chemotherapy, we don't routinely harvest now, as they were harvested when patients were on Ewing's 99. So our patients would only be harvested at recurrence if we're thinking about high dose. Yeah. You know, yeah, not in their primary disease.
Yeah, this led me to another question. Do you think, do we need another confirmation with this high dose chemotherapy approach? Because the scenario where this high dose demonstrated superiority did not include dose dense chemotherapy, for instance. So we need another confirmatory trial or not?
So I think that's always the ideal, isn't it? I think Natalie wants to say something, but that might be the aspiration, but whether that's the realistic proposition, I think is unlikely, to be honest, because it took many years and enormous collaboration to get to the data that there is now, and it didn't. And I guess you could say it didn't answer the question, but it has provided some signposts. I do think is that what we want to say, Natalie?
Yeah, it's unrealistic.
Yeah.
Because 15 years to do one, we will not do a second one.
No.
Clearly. And just we are using VDCIE for other disease. And if you want to harvest after VDCIE, it's better to harvest after IE. I agree with you that high-dose ifosfamide is better to harvest than VDC.
Okay. We have another question from Celso Melo. Do you believe in monitoring MRD after chemotherapy to indicate HDT, more selective indication after induction chemotherapy?
So I think if we were going to, I'm only talking about in the relapse situation now. If we were considering high dose, we would give the patient chemotherapy to achieve the best possible response, and then we would give them high dose as consolidation. We wouldn't stop chemotherapy and monitor them in terms of disease burden and then think about high dose. Does that answer the question?
Mm-hmm. Okay. Maybe there is any question from Dr. Windsor. Okay, thank you, Dr. Windsor, for your presentation. Now we are pleased to introduce Dr. Manuela Palmerini, a medical oncologist and investigator of the chemotherapy unit of the Rizzoli Orthopedic Institute from Italy. She tells us about new in advanced Ewing sarcoma. Doctora.
Thank you. I will share my screen now. And so I will talk about the news in advanced Ewing sarcoma, some will overlap with other talks, but I hope it will be useful for an educational purpose. It's difficult to identify new treatments in Ewing because it's rare, and also because it's, at least for the primary tumor, it's very chemosensitive, and so it's the tumor sample is really limited and decalcified. I want to underscore that we did some progress because of the recent finding that autologous transplant and busulfan and melphalan can be used in high-risk poor responders was confirmed by this study by the Italian sarcoma group that also compared in a randomized fashion to induction treatment, and apparently VA, so vincristine, doxorubicin, and ifosfamide for cycles is more produce a superior EFS, but this should be confirmed. And also timing to start this treatment, it's important. Uta Dirsten presented also at ASCO this year a study comparing retrospectively 21 delays from biopsy of treatment start in this group, and found that the patient undergoing a delayed treatment had the worst survival. So all these risk factors should be definitely taken into account in designing new studies. And again, the recurrent trial was already presented, and these are the treatment that we usually adapt in the advanced Ewing. The role of carboplatin etoposide, it's still under study, but last year at ASCO, Dr. McCabe presented this important finding on 310 patients. It should be underscored that 60% were primary refractory or progressing within 2 years, so aggressive people. And as primary endpoint, the high-dose ifosfamide and topotecan and endoxan stand out for a 3% advantage over temozolomide and irinotecan, and then gemcitabine docetaxel 11%. So this should be the sequence that we propose our patient. Unfortunately, the median PFS was only 4.5 months and overall survival 13 months. And these are the curves, and this is the winner. And I'm quite happy because Dr. Ferrari, my former head, was very into this treatment, but definitely we need more drugs. And also we might try to use better these ones. So irinotecan and temozolomide might be used up front, and Dr. Azaftei from our group presented the result of a window of therapy. So 2 cycles for very high risk patient with metastasis, and the response rate was really high. Last year we also had a small series treated only with temozolomide and irinotecan, and even the cohort was really small. We have at least 1 patient cured by irinotecan and temozolomide with bone metastasis, so this should be explored further. And also our pediatric friends with the neuroblastoma were able to combine this treatment with anti-CD2 therapy, dinutuximab or dinutuximab beta, which is interesting because combine immune effect to cytotoxic effect, attracting immune cell over tumor. And in this combination, of course, age is a very important factor, because these drugs should be infused very slowly over 10 hours, because they can produce very bad neurologic symptoms. And going back to the history of Ewing, we were very unhappy with the result of insulin-like growth factor 1 receptor targeted agents. There are several studies, also some predictive response identified, but none of these agents really worked in a all-comers study. Reason might be crossed also with insulin receptor, which might be a target from a dual inhibitor like insitinib. This study is still unpublished after several years, so probably not very exciting results. And the other reason may be the increase of EGF1 binding proteins. This is study for the Professor Scotlandi group that showed how a combination maybe with bromodomain inhibitor like GKU might be able to work synergically with the EGF-1 receptor inhibitors. And we already spoke about how nicely PARP or poly-ADP ribose polymerase repair inhibitors are active in preclinical model of Ewing as compared to other osteosarcoma or soft tissue sarcoma or epithelial cancer. These again are the summary of some of the study in monotherapy by Edmund Choi combined with trabectedin, Dr. Grignani, and this year Rasmi Chung combined with niraparib with temozolomide and irinotecan, just one partial response, and the olaparib and temozolomide study result are awaited. And luckily we were able to find some as predictors, PARP1 as said to PARP inhibitor, or SLAFN11, talazoparib combined with radiotherapy, and also as in ovarian cancer, homologous recombination deficiency signature and BRCA signature, and we might be able to find the best match using preclinical screen masses, like in this study by the pediatric branch at NCA, in which the nicotinamide phosphoryl transferase was resulted the best match with PARP inhibitor. So this might be exploited in the future in the clinic. And also cyclin CDK12 inhibitors were synthetic lethal in this Ewing in this model of tumor expressing Ewing FLI1. So maybe this might be something useful for patients in the future. And the big question, if genomic profile might impact on treatment decision as in Ewing sarcomas. There are some evidence that the genetic of Ewing is correlated with prognosis. In particular, we know that ATRX and IDH1 are associated with telomere elongation and telomere shorten, and telomere maintenance may represent a senescence escape, so a survival mechanism. And also high telomere activity was associated with poor progression-free survival in Ewing. So this mechanism might be important also for Ewing. And there were several genetic and study published in the past. Whole genome sequencing, whole exome sequencing were used. STAG2 stand out as expressed in about 15–18% of the patient, along with others like CDK and 2A or AZH2. So those might be considered, and also germline mutation in this more recent study by Broll. SEG2 is prognostic, especially when combined with P53. This is the mutant, this is the wild type, and this year there was another report for a series of Ewing by Foundation One, and this report confirmed that these Ewing are tumor mutation burden low 100% and all microsatellite instability stable. So that's why we shouldn't use immunotherapy like checkpoint inhibitor alone. But also found out the presence of this fibroblast growth factor receptor polymorphism, which was associated in 51% of the case, which was associated with other mutation. And this should be exploited more in Ewing's, and it is also reported in other cancer that this polymorphism is associated with elevated risk of cancer. I'm sorry, this study was presented at ASCO, and this is a scientific report on other cancer. So it would be nice to understand if all these mutations that we identify are associated with activity of this drug, like palbociclib for CDK4, or in case of VEGF or to pazopanib or other tyrosine kinase inhibitor. And there are match trial and GAINA-ICA2 study by the CAG group. I only presented the most recent, discussed at ASCO this year. In this pediatric population, there were more than 300 cases included, and 249 were considered for matched therapy. 13% were Ewing. So this picture is just illustrative to show you that if even if we sequence, we found we were able to perform match treatment in a small some number of patients, and in this study, 6 patients eventually on this about 30 patient population had an extraordinary response. So what we want for our patient defined as RECIST or PFS more than 4 months. Unfortunately, none of this patient was Ewing. Again, also this genetic study, this problem of basket trial, which hardly give us the right impression of a specific tumor. And so there are novel combinations we can be exploit as TKA and PARP in combination with other inhibitors, also epigenomic inhibitors like LSD1 or SH2, cell cycle inhibition, and also trabectedin, which are under investigation. We already discussed about Cabone, and the result presented to this year at ASCO from the COG group was less enthusiastic, with no partial response on 13 patients. And I think we should always look at the mechanism of action, and we are lucky that we have other solid tumor models to keep in mind. The cabozantinib inhibits, it's a dual inhibitor of vascular endothelial growth factor receptor, and MET was approved in 2017 in first line for kidney cancer, and this year the FDA approved cabozantinib in combination with nivolumab. So this also might be also an important combination. While in other pediatric solid tumor, there are lenvatinib plus everolimus. It's this treatment are also combining toxicity, and we should be aware of it. And then this was already presented, this first-in-class drug that inhibits Ewing FLY1, just to show you again the median progression-free survival, which was only 1.9. So I think that we should try to select the population somehow before designing the study, in order to get this patient on the top in this track, because 25 months in this kind of population, heavily pretreated, heavily metastatic, it's really, really meaningful. And the last word on immunotherapy, the median tumor mutation burden in Ewing sarcoma is very low. This is 2.5. Oh. From a table from Gonder presented at CITOS, and Ewing is right here, so about 2. And from AACR in 2018, we know that the threshold is 10, so Ewing are way below 10 for tumor mutation burden. So combining might be important. Sunitinib was used in this trial by DJs and the Italian sarcoma group, used as immunomodulant, 37.5 gram, and then in combination with nivolumab, 25 milligram a day. This is the table. This mistake was presented last year at ASCO, so 2020. And as you can see, 8 Ewing were treated. It's not a huge number, but no racist responses described. There was one patient that had a stabilization for at least 6 months. And these results are in line with the previous study by Tabi and colleague from the SARC 020A group, with 0 responses in 13 Ewing. So more immunocold Ewing as compared even with osteosarcoma and the differentiated chondrosarcoma. We were good, at least in these last years, to identify subpopulation of round cell tumor. This is a review that I contributed within the SELNET network, and this underscore how Ewing sarcoma is genetically different from other undifferentiated small round cell sarcoma like CHIKDAX4 and BCOR, which now they can be identified by FISH or by sequencing. And this study by Professor Scotlandy lab underscore how with the RNA-seq we are able to separate models of CHIKDAX and Ewing because they nicely separate in this model, and they were also able to identify an important pathway with the 7 most expressed genes that might be used as target. And as you can see, they found that proliferative signal in this CHIKDAX cell non-Ewing were dependent also from AKT mTOR pathway, and a dual inhibition with trabectedin and an mTOR inhibitor was able to fully suppress the tumor volume growth in this model. And in the future, we might have other technique that might guide treatment in the setting of advanced Ewing. There are several, but I presented this because I like the term licorice is just the acronyms for liquid biopsy region of interest coverage estimation, and this is a study in several pediatric cancer with low mutation burden, including Ewing. This liquid biopsy were performed in 95 Ewing, studied genetic and epigenetic changes over time, and this technique allow not to identify this aberration and also to follow those over time and might be serve for future study. Also, in the future, we should be aware of the role of germline testing in patients with advanced cancer, including Ewing. This study over 2,000 patients in about 50 malignancies found out as at least in the relapse setting, 8% of the patients had a germline mutation variant and received the germline genotype directed treatment. So the author conclude that germline sequence analysis is addictive to tumor sequence and should be considered for all patients with advanced cancer. So right now we were focused to split tumor from sequence from germline sequence, but the point of view that might be in the future totally changed, and that's might be maybe the way to simplify also this research. And I want to conclude with presenting this patient follow at our clinic. It was came here in 2007, and he had a hip Ewing sarcoma, which undergo chemotherapy and busulfan and melphalan in 2007. The tumor relapsed in 2003, and he underwent several treatments like Temiri, ifosfamide, gemcitabine docetaxel, pazopanib, and also an epigenetic drug within a phase 2 trial. And in the meanwhile, he had graft fracture, graft non-union, hip prosthesis, pneumonectomy, and also 3 or 4 times radiotherapy in chest wall, lung, and D7. I just want to underscore that the patient major concern, it's really incredible. He just was concerned to lose his job, and this is our president, Mattarella, and this is the employee of this guy that were awarded in 2019 because they gave his job they allowed this guy to keep his job after several years paying by their pocket. And I think that's really a nice gesture, but shouldn't be the way for our patient. So my take-home message for advanced Ewing sarcoma that more drug and more biology will help us to design active study design, but we should keep focusing on multidisciplinary team, both on clinic and bench side with molecular tumor boards. We should also consider survivorship. I was impressed that there are pediatric patients coming in our clinic that already have active surveillance treatment, but also gym program designed for survival, which is really important for the future. And also we should consider early palliative care in case of dramatic progression of the disease. All these activities are as important as a treatment itself. We should consider all the specific problem of this population, pediatric population, like as I just said with our young patient, work and education and reproductive and sexual life problems in this age group of patient. It's really important to support them also in these life tasks. And I think we can do all this just through collaboration. Ewing is a great example, SELNET consortium, but also national, regional network, and all the support that we can build together might be finally able to raise awareness. So thanks once again to SELNET group for this guiding us in that direction.
Thank you, Dr. Palmerini, for your excellent presentation. Now we have some questions from the audience. Celso Melo says, congratulations, and he have a question. Do you think the combination of trabectedin plus olaparib Thomas study is a tolerable regimen, or another DNA damaging agent would be a better partner for PARP inhibitors?
So I know that this regimen is tolerable very well, because I've been treating till last week a 78-year-old guy. Of course, we did an adapted schedule, and the olaparib was did after 11 years, so it was not a continuous infusion, but he had a soft tissue, metastasis from soft tissue, and it was interesting progressing both to adriamycin and ifosfamide. So I think that toxicity is an issue but can be managed. The problem is that the activity in Ewing was not, we treated only 4 patients, but was not judged enough to proceed with further study. So we will never know.
Thank you. We have another question from Andres Rodriguez. Which biomarker do you consider to be promising for use in daily clinical practice?
I like this question. I would like that PET scan SUV would become a biomarker, which is because I think that more than 6, as shown in one of our study in localized Ewing was a good threshold, but there are, I think, there are so many prognostic factors that we have to consider that it's difficult to select which one stand up. So more than biomarker in general, we need predictive factor, and more than predictive factor, we need factor to select the population. So we should not run especially with targeted agent all-comers study, because they jeopardize the results and might be detrimental for the study and for the patient at the end.
Thank you. And David Moura has a question. Knowing about the decalcification problems that affect the bone tumor samples, how can we be sure to have a reliable predictive biomarker at RNA level? Should we focus in protein?
I think I will turn this question to David itself. No, I'm joking. No, I think yeah, that prospective biobanking is important. We are doing it with fresh tumor biobanking in bone tumors, and our surgeon should be aware of it, and to perform large excisional biopsy to ago biopsy, but of course in the clinical practice it depends. And since that we just found out that in Ewing poor responder, the delays from biopsy to start treatment was so important for survival, I think that it really depends on institutional possibilities. So if we have a very strong radiational group that it's quicker, of course, sometimes we might lose the possibility to have more tissue. This problem is secondary for the relapse stage. Usually Ewing has a bunch of lung and soft tissue metastases, so we might be able to sample those, and we know that genetically all these tumors are heterogeneous and dynamic, so that would be also ideal for preclinical testing.
Thank you. Nadia have a question. Has TK216 opened a new way for Ewing and another translocation-related sarcomas?
That's very interesting, Nadia, but I'm not sure, because the results of the study are really, and also in the expansion cohort presented at ASCO. And I think we need to learn more on the patient which were responding before widen this treatment in other ultra rare entities, because the inconsistency of response was something that I really don't understand.
Thanks, Dr. Palmerini, and I would like to talk to the panel of experts for the excellent presentation that we have today, for the important messages on how to approach patients with Ewing sarcoma in the different stages of the disease. And now I would like to give the present to Dr. Castro. He has some words for us.
Thank the third speaker, Dr. Gaspar, Dr. Windsor, Dr. Palmerini. Thanks to the departing thanks and the SELNET Consortium for the opportunity to improve your knowledge in the diagnosis and management of sarcoma. Thanks and Dr. Martin Broto and Nadia. Thanks also.
So, Broto, Nadia, do you have any questions or any words for the event?
Just to thank you, because your organization of this webinar, I think there were 70 attendees, or at least 70 connections, maybe more people attending this webinar. So thank you very much for your effort. And these presentations, if the speakers have given the permission, will be uploaded in the SELNET website in a short time. So thank you very much, and we will see soon in the next webinar. Thank you, Nadia, as well. Thank you. Bye-bye.
Thank you.
Thank you.
Thank you.
Bye-bye.
Ciao.
Thank you.
Bye. Thank you.
Bye.
See you in the next webinar.
Bye-bye.